afternoon. Thank you for joining us for today's presentation, Genetic and Biomarker Testing for Alzheimer's Disease. If you have questions or comments during the event, you can place them in the chat. Our presenter today is Dr. Scott Roberts. Dr. Roberts is a professor at the University of Michigan School of Public Health. His research addresses ethical and psychosocial issues involved in disclosing genetic test information. He has studied participants' motivations and interest in genetic testing, the psychological impact of providing risk disclosure, and health behavior changes prompted by risk assessment. Dr. Roberts also has interest in mental health and aging, including public education about brain health and the development of support programs to promote successful aging. And with that, I will turn things over to Dr. Scott Roberts.
Well, thanks so much, Stephanie, and thanks everybody for joining today. Look forward to talking with you about a topic of great interest to me, genetic and biomarker testing for Alzheimer's. And yeah, as Stephanie mentioned, feel free to put questions in the chat. We're going to do, I think, the Q&A towards the end, but if something prompts you to have a question, you can, I think, put it in the chat at any time. So I'm going to start with just before we get into genetic and biomarker testing for Alzheimer's, wanted to just to do a little bit of background. And so, one question I often get is, what's the difference between Alzheimer's and dementia? They're often terms that are used interchangeably in the lay public. And so just as a reminder to many of you, dementia, is the more general term for a syndrome that has progressive decline in people's memory and thinking abilities over time. And so there's a lot of different causes of dementia. So Alzheimer's happens to be the most common underlying cause of dementia, but it's certainly not alone among the dementias. And some of you may have heard about, vascular disease, where you can have many strokes in the brain, or Lewy body dementia, or frontotemporal. So there's a lot of different types of dementia. I'm going to focus on Alzheimer's today because it is the most common type, but just wanted to remind us that it's not the only type. And in fact, to make matters even more complicated, a lot of times we have what's called mixed dementia, where people may have multiple things going on in the brain that cause cognitive impairment. And it might be a mixture of Alzheimer's pathology and other types of brain pathology. Now, when we talk about Alzheimer's, obviously, I mentioned it's the most common type of dementia. There's an estimated over 6 million older adults currently in the US affected by the disease. And there's a lot of focus on, what are risk and protective factors for Alzheimer's. So I'm going to focus on genetics today, but again, just wanted to note that it's not certainly the only important risk factor. In fact, age is probably the most important risk factor, which is probably not a surprise to this audience. Most people develop symptoms of Alzheimer's, in their 70s and 80s, and so age is a very prominent risk factor. Biological sex is an important risk factor. Women are at elevated risk for Alzheimer's compared to men. And, we'll obviously talk about genetics a fair bit today. Fortunately, there are a lot of protective factors as well. So even though it is a challenging disease in that our treatment options are limited, there are some things that can be done that aren't guaranteed to prevent Alzheimer's, but can at least lower one's risk. And so you can see some of these factors listed on the right side. People with higher levels of education. There's a growing adoption of the slogan, "What's good for the heart is good for the brain," because a lot of the factors that we know that are risk factors for heart disease are also risk factors for Alzheimer's and related dementias. So that makes sense to think about, managing hypertension, for example, has been shown to reduce risk of cognitive impairment. A lot of the things that we tell people just in general to do for their health are also potentially useful for preventing Alzheimer's and dementia. So maintaining a healthy diet. There's been some interesting studies, for example, on the Mediterranean diet in particular, as useful for promoting cognition in later life. And of course, exercise is really so fantastic for so many things, not just cognition, but mood So regular physical activity is, of course, recommended, and just staying more socially and cognitively engaged. So the Alzheimer's Association has a whole interesting campaign called 10 Ways to Love Your Brain if you're interested in learning more about what might be done to promote brain health. But you can do all of these things and still develop Alzheimer's disease. So, and part of that is because we do know that, as I alluded to, genetics is an important factor. So let's talk a little bit now about genetic testing for the disease. So there's many different types of genetic testing, not just for Alzheimer's, but in all of medicine, public health. And so I did want to remind us that we can use genetic testing for a variety of purposes in clinical practice. And you can see some of the different indications here. The ones in bold are the ones that are most relevant to Alzheimer's, but because I teach in our public health genetics program, I wanted to also put in a plug that in broader medicine, we're seeing the adoption of all kinds of genetic testing. It's really become very popular in cancer care now. Prenatal testing can be done. Pediatric genetic testing is often done. So there's a wide range of genetic tests that are out there. Sometimes we are testing for very specific genes where we're looking for a specific variant that's known to cause disease. But we're also seeing more and more use of genetic testing, for example, with panel tests, where it might be like in cancer, for example, that you might test for a whole set of genes, or even we're seeing the move now towards what's called whole genome sequencing, where you might sequence the entire genome and really cast a very wide net. And I think there's been some amazing advances in genome sequencing over the past couple of decades. It used to, at the turn of the 21st century, it used to take $100 million to do a whole genome sequence, and we can now do it matter for just a few $100s. So even though I'm going to talk about Alzheimer's, I wanted to mention that because I know some of you may work in other healthcare contexts as well. So I think we're seeing a lot of enthusiasm about the use of genetic testing for a variety of purposes. So the ones in bold I mentioned are the most relevant for Alzheimer's. So just to give a little bit more detail, we have a recent paper, if you're interested, that talks about some of these different kinds of tests. So I'm going to talk today a lot about predictive testing, which, as you can see here, we define as looking for rare genetic mutations where, if they are present, that it's almost certain that the person will develop Alzheimer's. We'll talk some about susceptibility testing. That is testing for variants that aren't nearly as predictive as the ones I mentioned for predictive testing, but can still confer increased risk. And then we'll talk some about pharmacogenetic testing, which is genetic testing in the context of informing treatment decisions, particularly medications where genetic variants might be relevant to how people respond to a particular drug. And so there's there's been tons of genetic research that have looked for all kinds of different potential genetic links to the condition. And so this graph I like to show because it shows how there are some very rare variants that are highly predictive that I'll get into. There's this ApoE4 variant that has an important link to disease. And then there's a whole set of variants that I'm not going to talk about as much that confer very modest risk. And so I think this graph shows that for some of the ones that are very highly predictive, they're very rare in the general population. Whereas ApoE is this very interesting case where it's relatively, the E4 allele is relatively common in the general population and still has a pretty prominent impact on risk. So let's start first with those rare, highly predictive genetic variants. So if you're a pop culture junkie like me, you may have seen the movie Still Alice, which Julianne Moore won an Oscar for. She portrays a woman in her 50s who is affected by Alzheimer's that's caused by a genetic variant. And so there are three, genes that are relevant here. So the presenilin 1 and 2 genes and the amyloid precursor protein. So these are and they're on chromosomes 1, 14, and 21. So if you have a mutation in one of these genes, this disease causing, then the disease will almost inevitably come to pass, often much earlier than our typical Alzheimer's cases. So fortunately, these are very rare variants, so they account for a very small percentage of Alzheimer's cases. But as I mentioned, if the mutation is present, we often see the disease onset can be even as early as in one's 30s or 40s, as opposed to the 70s, 80s, 90s that we usually see. And on top of that, if these mutations are present, the disease usually has a more rapid course. So the symptoms become worse more quickly over time than we see in more general types of Alzheimer's disease. And because this is what we call an autosomal dominant condition, if one has this mutation, then any biological children have a 50-50 chance of inheriting that mutation. So it becomes kind of a situation where the family has to think about the potential implications of the genetic test results. And so in the movie Still Alice, this was part of the drama. The adult daughters were trying to figure out, should they be tested? And if they were going to be tested, what would the good timing be? What would they do with the information? And so we do have genetic testing and counseling available for families where this kind of pattern has emerged. At the University of Michigan, we have a neurogenetics clinic where this can be done. But again, it's not relevant for the majority of the population because these are pretty rare variants overall. But when the testing is done, we often recommend that it's done with a genetic counselor, because these, if you don't know much about genetic counselors, they are master's level clinicians who really have expertise not only in medical genetics, but then also in patient education and support. So they're skilled at being able to communicate about what the results mean. They're skilled in providing the kind of support that might be necessary, because as you can imagine, if you learn that you have one of these rare variants, it can be a very psychologically distressing kind of experience. And so genetic counselors can often identify resources for patients and families in coping with this kind of distressing news. So, and genetic counselors really liked, unlike a lot of other medical tests where you might even be ordered without the patient knowing about it, the idea here is that it's a very thought through process. So there's usually pre-test education sessions to really think through the implications of what the results might be. Because again, in the context of Alzheimer's, they're not necessarily directly informing medical care. It's more in this realm of informing advanced plans or other life decisions that might be affected by this information. So there's a lot of focus on trying to make sure people understand what they're signing up for, that they're psychologically ready to receive this kind of information. And it's not something that they have to do. Sometimes people, after these pre-test education sessions, say, you know what, I don't think now's a good time, and maybe later. And so people might even opt out after the pre-test education. But then if they do decide to proceed, what happens is then there's the disclosure of results and providing recommendation for next steps. Now, one of the challenges here, and we'll talk about this in greater detail later, is that genetic counselors are relatively small in number. So there's not a lot of access on a broad scale to them. And so I'll talk about ApoE testing, for example, becoming more commonplace. And so I think this will be an interesting challenge, given that it's not like genetic counselors are as plentiful as social workers or nurses, for example. So the issue of finding and matching somebody up with someone might prove to be challenging. So that's a little bit on predictive testing. Let's talk about ApoE testing, which is usually done for susceptibility testing purposes. So ApoE is a gene on chromosome 19. There are three common alleles known as E2, E3, and E4. And as I mentioned earlier, E4 is the one that's linked to higher risk of Alzheimer's. However, E4 is neither necessary nor sufficient to cause the disease. So you could have an E4 allele and never get the disease. You could get the disease without having an E4 allele. And interestingly, ApoE is also relevant for other conditions. So the E4 allele is also a modest risk factor for heart disease. So just to kind of show you pictorially, so let's say you had one parent who had a 2-3 genotype and another parent with a 3-4 genotype. You can see there's a range of genotypes that might be possible in the children that this hypothetical couple might have. But another thing that's relevant here, so let's say you had a parent who had an E4 genotype, so they had 2 E4 alleles. It would stand to reason then that any of their children would at least have one E4 allele. So that's important to know because as we'll talk about, genetic test information can have ripple effects across families. And so if you find out you have a parent with an E4 genotype, you know that you yourself must carry at least one E4 allele. So in terms of prevalence of different genotypes in the general population, you can see that highest risk E4 is relatively rare, only 2%, but you can see over a quarter of the general population carries at least one E4 allele. So that's pretty common for a high-risk genotype. And so what does this mean in terms of risk of disease? You can see the general population risk we estimate to be about 10 to 15% chance of developing Alzheimer's in one's lifetime. And you can see that having one E4 allele roughly doubles that risk. And if you have 2 copies, what we call an E4 homozygote, you can see that the risk is many times the general population risk. So certainly not to the point of like a near 100% risk, like those rare variants I mentioned earlier, the presenilins and the APP, but still very an important risk factor to be aware of. So ApoE testing has therefore been on the radar for decades now, but it's generated a lot of controversy because it's kind of in this gray area of, well, is it useful? Should it be done? In what contexts, et cetera. And so it's not recommended for routine use in clinical practice. And there are a couple reasons why. First is, even though it is an important risk factor, it's not absolutely predictive. So I mentioned the neither necessary nor sufficient to cause Alzheimer's notion earlier. And that limitation in predictive value, coupled with the fact that we can't, unlike in other conditions, we can't put people on a statin like we do with heart disease to lower their chances. We do have some screening techniques like cognitive screening, but it's not like a mammogram or a colonoscopy where we have highly proven screening tools that can then ultimately lead to treatments that lower risk of the disease. So we're not there yet with Alzheimer's treatment and prevention. So that combination of the limited predictive value plus the limited treatment and prevention options has led the medical community to say, we don't think this is necessarily a great idea. On the other hand, there's a lot of people out there who are just very interested in learning what their genotype is, particularly those who might have a family history of the disease and might think it's useful for a variety of kind of planning purposes. And interestingly, just a few years ago, the genetic testing company 23andMe that you may have heard of actually obtained FDA approval to offer ApoE testing direct to consumer. So you can now spit in a tube, send a saliva sample into 23andMe, and you can learn your ApoE genotype along with a lot of other pieces of genetic information through this kind of service. And there are other kind of direct-to-consumer genetic testing companies out there that either might or do offer ApoE testing. So it's brought up kind of an interesting dilemma for the field as to what should we tell patients and families who might be interested in this information. And in fact, our group here at Michigan and some of our colleagues across the country, we have done a range of studies actually in a research context offering people the chance to learn their ApoE genotype and then studying how do they respond to this kind of information. So what we found in doing these kinds of studies is that if people get decent education, that they understand what the test results mean. I think there was a lot of concern people would overrate the importance of this information, because genetics has that connotation of being highly predictive. But we found that with education, people understand the limitations of the genetic test. And perhaps even more importantly, we found that people did not generally respond with clinically concerning distress, even if they got bad news. There was a lot of hesitance in the medical community that, oh, we'd be saddling people with potentially harmful information. But we found that was not the case, at least in the populations we studied. We also try to look at, can we do the genetic education and counseling in a more streamlined manner, not very time-intensive, multiple sessions. And so we found that we can do this in a way that's not going to take multiple hours of face-to-face time. And so we've developed some protocols to do this even by phone or web and in a more brief format than is usually done in genetic counseling. And we found that the test results prompted an interesting range of responses. So people did do a lot with their information. It maybe inspired certain kinds of health behavior changes, some kind of advanced planning. So I wanted just to kind of comment on those. Some of those were in the directions we were hoping for. Like some people, it did seem to make a difference, maybe motivating them to change diet and exercise. But some changes we were less certain how excited we were. So a lot of people, for example, reported taking nutraceuticals. So there's like a growing market now of anti-aging nutraceuticals out there. And so you can see kind of some examples here. My concern here is not necessarily that it's physically harmful for people, but I just don't know if it's a great use of their hard-earned money, because the FDA does not evaluate nutraceuticals in the same way that they do medications. And so there is, I think, the potential for some of these products that really aren't delivering any true benefit, but maybe capitalizing on people's fears about aging and dementia. So that was one interesting finding. Another one had to do with this issue of genetic discrimination. So I wanted to tell you a little bit about this broader topic of genetic discrimination. And in fact, there are legal protections against use of genetic information against consumers and patients, known as GINA. So this was passed in the Bush administration back in 2008. And so it's a federal law that actually prohibits the use of genetic information by both health insurers and employers. So it is illegal for a health insurer, for example, to do a genetic test and say, oh, we're not going to cover you because you're at high risk for Huntington's or high risk for cancer. So that's not now allowed under law. And neither can employers do this. So employers could not use genetic information against employees in terms of, hiring, firing, promotion. So I think this makes sense. It seems like that would be a highly unfair thing to do. But I think in the context of Alzheimer's testing, it's important to recognize that GINA does not apply to certain types of insurance. So health insurance, yes, but not long-term care disability or life insurance. So that's not to say that these industries are actively using genetic information against people. I don't think that's the case, but just to point out that this is, a limitation of the legal protection afforded by GINA. So it may be useful for, if people are thinking about genetic testing, to think about it, are they planning to apply for any of these policies and try to do their homework on whether or not their carriers would want to know about any kind of genetic risk for Alzheimer's as part of this decision-making around long-term care insurance, for example. Genetic testing is done a lot in research studies. So it's routinely collected both at our site and many others across the country. And I think we are seeing a move, because it's become so easy just a drop of blood, you can detect, all kinds of genetic information. And I think the field is also moving more towards what we might call polygenic risk scores. So the idea of not relying just on ApoE alone or the presenilins alone, but trying to combine information from a whole range of genes. And we've seen in a lot of other conditions we're going to have more powerful ability to predict risk for conditions if we do these polygenic risk scores. In the research side of things, people's individual genetic results usually are not given back to them. It's just done more for research purposes. But we and others are more actively offering people the chance to learn their genetic status as part of these studies. And it's also become a key part of determining eligibility for some of these newer prevention trials where we're trying to test medications that might actually prevent Alzheimer's in people who don't yet have any symptoms. So there's been a range of these trials done now, and you can see some of them. We'll get more into biomarkers in just a little bit. Some trials have identified high-risk people through biomarkers, but some of them have used genetics to identify a high-risk population. One very famous one that you may have heard about was this Alzheimer's prevention study that was actually done in South America, in Medellin, Colombia, where they did find people who had those rare mutations I mentioned earlier that almost inevitably cause the disease. And so that was a means of identifying a high-risk group that they then followed. Unfortunately, it was just announced last year that trial, when they followed people over many years who were at high genetic risk for the disease. And so it was a decade-long study, and they tested a particular drug called crenuzumab that was an anti-amyloid therapy, and they just reported the results last year that did not seem to make a difference in terms of staving off the condition. And so this has brought up has been part of a broader debate in the field. A lot of the therapies have been focused on one pathology in the brain, known as amyloid. You may have heard these amyloid plaques are kind of a cardinal feature of the disease. A lot of the focus has been on drugs that are trying to address the amyloid plaque deposition in the brain, and a lot of them have not been successful. But some have, and we'll get into that. And I think it also relates to genetic testing in that for some of these newer therapies that are coming online, genetic tests can be useful in informing whether it's smart to go on that particular medication, because genetic differences might have something to do with how the drug is metabolized. We see this in other conditions beyond Alzheimer's, where you might want to do a genetic test to help understand, is someone going to be what we call a poor responder? Might they be at elevated risk for drug side effects? So, some drugs have black box warning labels, like before you prescribe this, make sure the person does not have this rare genotype, because they might have a very severe reaction to the medication. But in the context of Alzheimer's, ApoE testing is relevant. So I mentioned ApoE testing in terms of susceptibility testing earlier to predict risk, but it's also potentially useful in people who have Alzheimer's disease already to help them make decisions around some of these new FDA-approved medications. So you may have heard about Aduhelm and lecanemab are now are new treatments for the disease. And so the reason why ApoE testing is relevant is because it might help predict who is at higher risk for this side effect known as ARIA. So ARIA stands for amyloid-related imaging abnormalities. And so it refers to potential side effects that might include things like, slight swelling of the brain or microbleeds. And so these are usually, fortunately, benign. So even if they can be detected on neuroimaging, they don't usually lead to concerning symptoms, but they can lead to mild symptoms like headache or nausea. And in very rare cases, they can actually lead to more severe outcomes like hospitalization or even death in very rare instances. So ApoE4 carriers are at elevated risk for that side effect. And so ApoE testing is recommended now to inform these new treatment decisions. And I'm going to show you a very complicated slide, but hopefully it'll help you see why we care about this. You can see, in this left-hand column is like in this phase 3 lecanemab trial, these were kind of the various types of ARIA that were looked at, these side effects I mentioned earlier. And you can see the rates are very low in the placebo-controlled trial. But if you look all the way on the right, the people who have two copies of the E4, that E4 genotype, and who were on the experimental drug lecanemab, you can see almost a third had some kind of ARIA-E side effect of the drug. Luckily, this did not translate into symptoms. Often, only 9% had a symptomatic form of ARIA, and only 2% had a serious event for that. The ARIA-E stands for the edema, which is more the swelling. And there's another type, the H stands for is hemorrhagic, so the brain bleeds. So you can see among the E4 homozygotes, it's relatively rare that they're having serious symptoms, but they're still at much higher risk than both the placebo group and those who don't have the E4. So I think these kind of data are why the experts in the field, that these appropriate use recommendations for lecanemab just came out. So these are kind of a group of experts who thought long and hard about, well, for this new drug lecanemab, what are the appropriate uses of it? So as part of their appropriate use recommendations, they did come out and say, we recommend ApoE genotyping of all treatment candidates before initiating therapy. So they would recommend that if you're a patient with Alzheimer's, you're considering this new drug, that you learn your ApoE genotype to help you and your doctor decide, does it make sense? Maybe it does make sense to still go on the medication, but maybe, for example, you might be suitable for more aggressive monitoring to make sure these ARIA side effects are not occurring. So I think it makes logical sense given the link between ApoE4 and risk of ARIA. But again, just from a broader societal standpoint, I think it also raises some interesting questions, because ApoE testing is not done that frequently right now in medical practice. But we're talking about potentially millions of Alzheimer's patients being candidates. How are we going to handle this rapidly increasing demand for ApoE testing? I think it poses some challenges at the workforce level, because usually ApoE testing has been done, or other kinds of genetic testing has been done by genetic specialists. We'll have to think about training, neurologists, nurses, geriatricians to be able to do this kind of testing and patient education. And of course, we're talking about people with cognitive impairment. So some of the complexities of conveying this information, it's already hard enough with a cognitively intact, educated person, but how do we handle these informed consent issues and risk communication issues with folks who are dealing with cognitive impairment? Some challenges there. And then the family systems issues, I think, are going to be interesting, because as I mentioned earlier, let's say the ApoE test shows that someone's an E4 homozygote. As I talked about earlier, all of their adult children would then know they're also E4 carriers. And how would that ripple effect of that kind of information be handled in families? So I think we need to think about how we're going to prepare our healthcare workforce for the challenges of expanded ApoE testing as some of these new drugs start to be put into practice. Of course, people often wonder, well, what should you tell your patients or even friends or loved ones if they say, well, should I get genetic testing? And again, the medical community has been pretty conservative. So these are some joint practice guidelines. And you can see this quote suggests, steering away from this kind of testing, particularly in a direct-to-consumer format. I tend to feel like these are probably maybe a little bit too conservative. I don't think we need to be this categorically opposed. But I do think the idea of people thinking about it ahead of time, because it is easy now through 23andMe and other services to do this. At least you want people to kind of have thought through the pros and cons. There is actually a nice online tool for people who are thinking about this decision, this genetestornot.org. So it's an online decision aid that walks people through the pros and cons, gives them some education about the benefits and risks of ApoE testing. So I think these kinds of decision aids, because again, they're purely online and automated, And once they're developed, they're very low cost. I think they could be useful tools in this space. So that's some background on genetic testing. So hopefully it's useful for you to think about the different types of genetic testing available, what's involved, the information you can learn or not learn. I want to shift gears for the remainder of our time to biomarker testing, which is also raises some related issues, but is very important in Alzheimer's as well. So when we talk about biomarker testing, it's helpful to think about, what's known as the Alzheimer's continuum. So you can see it makes sense that because this is a slowly progressive disease, that people, develop symptoms over time. They start out having no symptoms, start to have mild symptoms, but retain their functioning, and then start to have the symptoms start to interfere with their life. And so we've seen the growth because of biomarkers in what we call, you can see on the left here, this preclinical AD space. And so it's been really fascinating to see how it used to be that we really only studied people once they, presented with symptoms. But because of biomarkers, we can now look at people many years before they develop any kind of symptoms and detect initial potential signs of the disease. And so the disease has become one not only defined by symptoms, but actually by these biomarkers that we can detect. And so it's thought now that there's a whole kind of course of events that may happen even decades before people have any kind of problems with memory or thinking. And so I mentioned amyloid earlier. So that's thought to be kind of the first step in the process, that these amyloid plaques start to develop in the brain, and maybe they start even 20, 30 years before any symptoms occur. And then it's thought that the next stage might be some inflammation occurs. Then ultimately, to have a definitive diagnosis of Alzheimer's, amyloid plaques is one component, but also these tau tangles are another absolute requirement. So the tau tangles usually develop after the amyloid plaques, but are also an important part of the disease. And then once the plaques and tangles start to develop, ultimately we start to see, cell death, neuronal loss, atrophy of different types of the brain. And then that's when symptoms start to occur. So it's a very complex process. We're still learning about it, even decades into research. But that is the general thinking, is that there's this kind of cascade of events that, and the reason why there's been so much focused on amyloid is that's thought to be kind of the initial triggering part of the event. And so the hope has been, can we interrupt this process upstream and therefore, prevent the disease hopefully someday. So that's the hope. And so I think we've seen a shift from a lot of treatment trials historically have been once people are already symptomatic, but we've seen a lot of focus on, trying to intervene in this preclinical phase, or at least at this MCI or mild cognitive impairment phase, before people have, functional impairment. So I think that's the kind of a big picture view of the disease and some of the treatment approaches. And biomarkers are really essential in identifying who might have this AD pathology already starting to occur. So I wanted to give you this background before we jump into the specific types of biomarkers. And in fact, these biomarkers have become so important that on the research side of things, there's been a movement towards what they call this ATN classification scheme. So basically classifying people as to whether or not they have the presence or absence of A for amyloid. Do they have amyloid plaques developing in the brain? The T is for the tau tangles I mentioned. So that you could have tau pathology or not. And then the N stands for, is there neurodegeneration going on? So that issue of brain shrinking, atrophy, et cetera. And so the A, T, and N can be detected in a variety of ways. So you can use neuroimaging. CSF stands for cerebrospinal fluid, so that can be a lumbar puncture. And as we'll talk about, blood tests are now coming on board. But a lot of the focus has been on neuroimaging, PET scans and MRI, for example. But there's different ways to get at the A, T, and N in this framework. But by virtue of this, this classification scheme is such that people would be kind of positive or negative on each of those three dimensions. And so in the ATN framework, you really are talking about kind of a range of outcomes. So what we talk about as Alzheimer's disease, I think on the research side, the researchers are saying, can we get more precise about these different components of neuropathology? And so, but I think what's interesting from a public health standpoint is there is quite a lot of older adults walking around out there who have at least one of this A, T, or N. In fact, 47 million. And many of them never go on to develop dementia. So I think from a research standpoint, it's very interesting. We need to be very careful before putting this into practice that we don't think about, the potential issues of stigma and labeling people with these biomarker test results. So biomarkers, it's been an interesting evolution over time. Back in the 1990s, the focus was really more on using these what are colloquially called spinal taps or lumbar punctures to obtain samples. But then in the 2000s and 2010s, we've seen the rapid rise of PET neuroimaging to detect both amyloid and tau in the brain. And then more recently, we've started to see the development of these blood-based biomarkers, which are really exciting. So amyloid imaging, just to say a little bit more about that. So in amyloid imaging, it's done usually via PET scan. And so they inject a tracer in the bloodstream that binds ultimately to amyloid plaques in the brain. And you can see an example of the image here on this slide. And so it used to be we would have to wait until autopsy to see our amyloid plaques present in the brain. But the FDA approved amyloid imaging for clinical practice back in 2012. And so the idea is that amyloid imaging can be useful in assisting with a diagnosis of dementia. So let's say, for example, you're a physician, you have a patient, they have cognitive impairment that's developed over time, but you're not sure of the underlying cause. Is it Alzheimer's? Is it vascular? Is it Lewy body? So amyloid imaging might help rule in or out an Alzheimer's diagnosis specifically. So even though it's been FDA approved a while, it's not yet covered by Medicare unless you're part of a clinical trial. I think the concern from Medicare is it's a very expensive test, and given that we have so many people developing dementia, they did not want to open the floodgates to paying for these expensive scans until they had better sense that it's truly going to be a useful tool in medical practice. So they have what's called, it's covered with evidence development. So it's only covered if you're part of a major trial. And I'll talk about one of these trials known as the IDEA study in just a little bit. So it's not yet recommended for people who are cognitively normal, even though we've actually done a study where we did provide it just on a research basis, but it's not in clinical practice available to people who are cognitively normal. So IDEA, as I mentioned earlier, so this was a major trial led by my colleague, Gil Rabinovich at UCSF. So they enrolled over 18,000 patients across the country to look at what was the utility of doing amyloid imaging. They were looking at, did it change patient management? Did it change some downstream healthcare outcomes? And just to make a long story short, they found that the amyloid PET was very useful to clinicians. It did seem to change how they manage their patients a majority of the time. So over 60% of both their patients with MCI and dementia, amyloid PET seemed to be a useful tool to them. And it really did make a difference in terms of even what was the basic diagnosis of the patient. So sometimes, if it was an amyloid negative result, it might change the diagnosis from Alzheimer's to another type of dementia, or maybe they had a provisional diagnosis of a different dementia or just dementia in general. And it allowed them to make a more precise diagnosis of Alzheimer's, which then might have implications for the kind of medications that were prescribed, the planning that was done, et cetera. It had less of an impact on some of these other downstream medical outcomes like hospitalization. Fortunately, they also looked at, did it cause significant distress to participants to disclose to them, for example, they were amyloid positive? Unfortunately, it did not seem to be the case. But one challenge in this trial, and it's a challenge for Alzheimer's research more generally, is that there was not a high rate of referral of different racial ethnic minority groups. So you can see relatively low enrollment from African Americans and Latinos in this. And so that has inspired this group in this follow-up study, new ideas to try to be more intentional about getting diversity in the patient population. So this was launched a couple of years ago. We do have 2 sites in Michigan that are now enrolling. You can see listed here. And so there's a really explicit focus on trying to diversify the sample. So it'll be interesting to see, hopefully, if there are positive results from this new ideas trial, that Medicare might move towards just covering this more generally, as opposed to saying you have to be part of a trial in order to get your amyloid PET scan covered. So that's a little bit on amyloid imaging. Another kind of imaging is tau imaging. So tau imaging, I mentioned those tau tangles in the brain being really important. So a similar approach here in that it's a PET scan modality. The idea is that a tracer binds to tau in the brain to detect how where is tau present and how diffuse is it, how dense are the tangles, and so more recently than amyloid imaging, we've seen FDA approval of tau imaging. This fluorotaucipir tracer is now FDA approved. But similarly to amyloid imaging, it's not yet widely used because of it's not covered by Medicare as of yet. Tau imaging is important because tau tangles are actually more predictive than the presence of amyloid plaques of cognitive impairment. So it's a little bit more tight correlation between tau tangles and cognitive impairment than the presence of amyloid plaques. But both amyloid and tau need to be present for a formal diagnosis of Alzheimer's. And of course, tau imaging can be used for the detection of other tau-related dementias like frontotemporal dementia. So I think we're seeing a lot of excitement and use of tau imaging. It's not as far along in its development as amyloid imaging, but I think we're going to see both being used more frequently in both research and clinical practice in the years to come. The last part I'll talk about is we've now seen the development of blood-based biomarkers. So this really became a huge, front page news of the New York Times back in 2020. So the big international Alzheimer's meeting is known as the AAIC, the Alzheimer's Association International Conference. So it'll be held this year in Amsterdam in July, where there's going to be findings of a new drug called donanemab. So everybody's waiting to hear about the results of that trial. But a couple of years ago in 2020, the big news was the development of these blood-based biomarkers. And so what happened was we saw kind of a range of findings from different groups around the world. And a lot of it used this particular blood test called p-tau 217. So this is a way in which, through a blood test, they could detect the presence of tau in the brain from a simple blood test, which was pretty amazing. And I won't get into all the nitty-gritty of the details, but the idea was that it really seemed to be a highly sensitive and specific test for detecting presence of Alzheimer's disease pathology. I mentioned that earlier study in Colombia of the people with the rare genetic mutations. So that study, blood tests in that population seemed to suggest that we could start to pick up these biomarkers, up to decades before any symptoms of the disease were occurring. And as you might imagine, people get really excited about this because amyloid and tau imaging that I just mentioned require, a very specialty clinic that can do this very highly technical approach. A blood test is much easier to do. So the idea of being able to scale this up and do this, in kind of community settings where they might not have access to the very high-powered imaging is something I think people are getting excited about. It's not yet ready for prime time. I think there's still work to be done. We still need to see replication, outside of these very kind of specialty academic medical centers. But I think there's hope that these blood-based biomarkers may start to be coming in use in clinical practice and perhaps maybe kind of as an initial screening test to decide who really needs kind of a more advanced workup to try to look for presence of Alzheimer's. And so I think it's got a lot of potential. And we're already starting to see, this isn't a p-tau 217 test, but there are companies out there. This precivity test is an example of a blood-based biomarker where they're looking for detection of amyloid plaques in the brain. And so we're already starting to see neurologists being approached with some of these blood-based biomarkers. And so it's kind of an area to keep your eye on as the, not only as the blood-based biomarkers get better, but as our treatment and prevention options for the disease get better, then obviously the test is going to be more useful if we can, offer patients and families more options in dealing with the disease. So to wrap up, hopefully you saw how there are, a lot of different types of genetic testing for Alzheimer's out there. None are recommended as standard of care, but some might be worth considering in different contexts for different reasons, either to predict people who might be at risk for disease or to inform treatment decisions like we talked about with the lecanemab case. Similarly, biomarker testing is now possible in a variety of ways. It's already being used to assist in the diagnostic process and can also be used to track treatment progress. It's not yet recommended, though, for those who don't have any symptoms of Alzheimer's or dementia. I think hopefully you've seen how in any, whether genetic or biomarker testing, these are pretty weighty decisions that ideally are going to involve thoughtful consideration of both the benefits and risks of testing. So patients and family members should be thinking about what are the implications, and professionals should be helping guiding them through those pros and cons. And then I think, as I mentioned just now, as we see treatment and prevention options improve, I think that's going to make the value of genetic and biomarker testing improve as well. So I think we're going to see there's a lot of attention, a lot of investment on both the testing side and the treatment and prevention side. The NIH budget, for example, for Alzheimer's has dramatically increased in recent years. So hopefully we'll see some continued progress in the years to come in both of these areas. So I also, before stopping, just wanted to put in a plug for our Alzheimer's Center, where some of these studies I've mentioned have taken place. If you or someone might be interested in taking part, we have, we're one of, I think, 37 now such federally funded research centers in the US. We have a variety of programs, so you can see our website listed here. So would encourage you to check out our website in case there might be something going on that's of interest to you or the patients you serve. So with that, I think we have a few minutes left for questions. So I'll stop sharing and see if I can take a look at some of your questions. So I got a question here. So one question is, ask you, where could you be tested for these biomarkers? So the genetic test, as I mentioned right now, to be honest, the easiest way would be through one of these direct-to-consumer companies like 23andMe. So that would be possible. You just have to submit a saliva sample through the mail. But as I mentioned earlier, I wouldn't just kind of sign up, without thinking through. And so the second question is access to this PowerPoint. I'm happy to share the PowerPoint so that could maybe be disseminated later. So there is this online decision aid that walks people through the pros and cons of the ApoE test that is available through 23andMe. So that would be one possible way to get access to genetic information, but I wouldn't automatically recommend it. I think people should think through, understand what are the pros and cons of learning genetic information. In terms of the biomarker tests, the amyloid and tau, that would only be available, through, a specialty medical care provider. And so I would encourage you to follow up, with your physician to see, does it make sense? And right now, like I mentioned earlier, it would likely not be done in someone who doesn't already have some symptoms of the disease, because right now the biomarker tests are most useful in what we call making a differential diagnosis. So you're trying to help determine what's the underlying cause of an existing cognitive impairment, as opposed to will I get this disease one day? So we're not quite there yet in terms of the biomarkers and saying this should be done with cognitively unimpaired older adults. So hopefully that helps answer Frank's question. And then Camilla and Carolyn are asking for the PowerPoint. So what I can do is I can share my slides with the host, and Karen, I don't know if you can comment on, I don't know if you have like a listserv or ability to follow up with people by email to share. Also, I believe this is being recorded too, so you could also, I think there will ultimately be a link to this recording such that you could review the section where I was maybe talking about something of interest.
Yeah, so we do have a list of all of the participants. So once we receive the PowerPoint, we will send it out to everyone. And we will be putting the recording of today's webinar up on the YouTube page, at least on St. Clair County Community Mental Health on our page, so that people can access it through there. And it doesn't look like we have any other questions. So if I don't see anything else come in, I think we can probably wrap it up. I thank you, Dr. Roberts, for today's presentation. Thanks to all of you that joined us, and I hope you all have a great rest of your day.